Hello, everyone, and thank you for joining us for our one-on-one discussions with the researchers in the MIND Project to Cure Paralysis. My name is Dalton Dietrich. I'm the scientific director of the MIND Project, and today we have the pleasure of speaking with Dr. Mark Nash. Mark is a professor in the Department of Neurological Surgery and a very important member of the MIND Project to Cure Paralysis research family. Good morning, Mark. How are you doing?
Good morning, Dalton. Well, thank you.
Very good. Mark, you've been with the project probably longer than anyone else except for Dr. Barth Green. Tell us about, the history of what your research has been in my project, and what research are you doing currently to really help people that are aging with spinal cord injury?
As you said, it's been about 35 years, and it predates to the beginning of the project. Dr. Green hired me actually in late 1984, and the project was coalesced in probably mid to late 1985. Our research has morphed through the years. It's changed, as we've learned more about spinal cord injury, so we haven't been static with that respect. We started in a small laboratory, and obviously we're in a big space now and looking forward to our move to the new Lynn Center, where we can better integrate our studies with acute injuries, people who are acutely spinal cord injury, which is something we've wanted to do for a number of years. Our primary focus has been in the area of cardioendocrine disease, which is a secondary complication sustained by a high percentage of people with spinal cord injuries. And that is an endocrine disorder. It has to do with their endocrine systems and causes the gain in weight, the lipid abnormalities that we've documented in lots of papers and lots of grants, and as well as other secondary complications which predispose them to early diseases of the heart, of the lung, and of the endocrine system, such as diabetes.
That's very interesting. You have been working quite a lot with the Diabetes Research Institute at the University of Miami. What types of collaborations are you doing with them?
Well, one of the things that's changed over the years, if we look at how the project has grown from essentially 2 rehabilitation research laboratories and several neuroscience laboratories, is I think we're somewhere over 30 laboratories now.
Mm-hmm.
And the amount of crosstalk that goes between the investigators is one of the largest changes that's taken place. Where we used to silo ourselves and each of the laboratories was investigating individual issues. Our integration right now is, I think, one of the real strengths of the project. We work with Diabetes Research Institute, but also an awful lot of work with our home base, the Department of Neurological Surgery. We're widely integrated now with the Department of Physical Medicine and Rehabilitation, the Department of Medicine. I think there are 7 or 8 departments at the medical school that we're now working with, as well as a number of centers, not just throughout the United States, but throughout the world, so that we can increase the number of research subjects we have in our studies, as well as appreciate the complexity of issues that are seen worldwide with spinal cord injury. We've taken advantage of the Diabetes Research Institute in particular because they're an NIH-funded center. They have excellent laboratories and some very, very skilled clinicians. And in that way, we don't have to replicate skills within our laboratory that are existing throughout the medical center. And that just makes us more efficient. The same thing is happening throughout the project. If we look at the clinical trials division, headed by Dr. Katie Gant, these are centers that didn't exist within our center 35 years ago, and now we're one of the largest trial centers in the world for looking at transplanted tissues, bioengineering, and the teams that are put together, involve neuroscientists, engineering, neurosurgeons, therapists, and so we've really expanded beyond the silo model that we really began with, and still a lot of centers use into something that uses as many skills as we have throughout, not only our Center of Excellence, but throughout the entire University of Miami Miller School of Medicine. The other way in which we've expanded, and we've really shown it in the past month that we've been out for COVID-19, is to use the infrastructure of the project. You know, our web managers, people who know social media as a way to reach out to people and more effectively engage them while, you know, all of us are not directly in the Lois Pope Life Center carrying on the studies that we have.
Yeah, and when we're talking to the scientists and we're talking about, you know, how is the pan-epidemic changed the way you do science, it's very interesting how we've merged into this remote teaching, research, things of this nature. And of course, you've got a big program now in terms of pulmonary exercise and pulmonary function, which is an extremely important component of, again, people living with spinal cord injury.
Well, we kind of saw this coming, Dalton. You know, a couple weeks as the COVID pandemic emerged, we started talking among ourselves, you know, the scientists who are involved in our projects, the clinicians who do the daily work, and even our research associates who actually do the exercise or the respiratory function. And, you know, we saw that we were probably going to be socially distanced. Okay? And our first question is how do we prevent that? You know, while we can't be in the same building, and there's certainly things that we would need to do as part of our grant work, drawing blood, doing exercise tests that we can't do at the moment, and we're hopeful to get back as soon as possible. There were other ways in which we could have outreach, and you know, when we saw supplies diminishing for disinfection and, you know, for our safety and the safety of the people who come to our center, we started planning almost immediately with, you know, the webmasters and people who know social media better than I do. You know, how do we reach out? What should we be doing? What platforms are among our options for outreach? And the first thing we decided was that we could take our physical activity programs and put them on a Zoom platform. And we tasked, again, even before we left the building, for the development of what we normally do in Lois Pope with respect to both grant exercises and the clinical exercise that we provide to the constituents in our catchment. You know, how do we do this, and how do we make it real? How do we make it safe? How do we make it effective? And, you know, even looking forward, if there's a silver lining in this, and I know it's hard right now for people to think that way, but we had never been challenged to really go out and look at how do we create distance exercise programs for people who can't come to our center because they're ill, because they don't have transportation, because, as we've shown in our studies, there are barriers to some of these things: transportation, financial, you know, certainly expertise of people who are going to health clubs and other places that don't know a lot about spinal cord injury. How do we create that? And, you know, this scenario with the pandemic has forced our hand, and we've responded with exercise programs live, you know, that we do twice daily, 3 times a week. And actually, not only does this provide an exercise platform for the people who are in our research studies and who have spinal cord injuries in the community who wanted to just use them, but we've also used them as social platforms for discussion of issues, for crosstalk in solving problems. You know, the people who know spinal cord injuries best have spinal cord injuries. Right. So they're offering, you know, explanations. We've heard discussions about where can you actually get catheters, where do you actually go when you're ill or suspect you are ill. And a lot of the social crosstalk has been very valuable for the people who are logging in. And now those are on our Facebook page. You know, we've reached out by Instagram, you know, to let the local peer support groups into this. And we've reached out to some of the local foundations to invite them into this. And this continues to grow as we gain expertise in how to deal with the nuts and bolts of putting on a distance exercise program.
And of course, we had to do this because of the pandemic, but, you know, in the future, we're going to continue. That's what's really exciting, right? We can be able to continue to use these new approaches, these new techniques, distance learning, doing actually rehab remotely to actually continue some of our studies. And that's going to allow us to reach more subjects, which is really, really exciting. Now, you mentioned exercise conditioning programs and nutrition. You're involved in that quite a lot as well. We have reached out to project in terms of trying to also collaborate more with our engineers and you work a lot with robotics. Can you tell us about robotic systems and how they're helping you in terms of physical fitness and exercise programs in people living with spinal cord injury?
Well, we've published a number of studies looking at the utility of robotic exoskeletons in daily life or in rehabilitation. And there are two possible options for using them. One is they provide a means of transportation. And this is I guess, a long-term goal where we have equipment now that has the capacity to reanimate or provide transportation. Now we're kind of challenged as scientists to find the best use for that equipment and where it is financially economical, where it is available to a wider spectrum of the population. We kind of went through this back in 1984 when the first electrical stimulation systems came out. When FES came out, nobody knew exactly what it did. Nobody knew exactly what the benefit was, and nobody knew how we would provide both initial training and what we called aftercare, so that people can use this long term. And we're kind of going through the same process now with the bionic exoskeletons. We have a capacity to walk. We have for many people with spinal cord injury, but we're not certain that they can walk easily through the community. Is this something that they use in daily activities, or is this possibly a health alternative to other exercise programs? Or do we use this early in spinal cord injury to reestablish in people with incomplete injuries their gating patterns, basically neuromotor rehabilitation? We're now that we're moving into the Lynn Center, we can work early on with patients, especially with incomplete injuries, to see if this won't hasten rehabilitation, even as a transitional strategy to those who can walk, those with Asia Impairment Scale C and D, because that's about half of the population, to enhance their rehabilitation. Again, early in intervention, where it may be doing the best good. We haven't had that opportunity for many years because at the Lois Pope Life Center, we're kind of separated from rehab. But with the planning for the new rehab center and our work with Dr. Gator in physical medicine and rehabilitation, we have access to an early intervention population and the physical therapists and occupational and recreational therapists who work with those people immediately after injury to see where this best fits their rehabilitation programs, their neuromotor enhancement, and their activities, satisfaction, productivity, and ultimately their health.
Yes, you mentioned several times now the Christine Lynn Rehabilitation Center for the My Project Cure Paralysis, and it's a beautiful alliance between the My Project, University of Miami, and Jackson Memorial Hospital. I've always thought that it will give us the opportunity to more seamlessly move some of our experimental techniques into a larger patient population. So it's exciting opportunities for us working with that. There will be challenges, but I think we are really excited about this particular new venue of patients. As you said, we can potentially target acute injury, subacute, and more chronic, but also potentially using some of our technologies to target other neurological problems, maybe such as stroke and traumatic brain injury.
Well, one of the things that's changed the most in 35 years, as I see it, is our vision of translation of preclinical studies, animal studies and experimental studies, or even new ideas, that we test experimentally in humans to clinical practice. And a number of the things that we've done, certainly in exercise, now in nutrition, we're mainstreaming them. And that wasn't our initial vision in the beginning, other than ultimately getting to the point where we invested tissue in people and we looked at essentially nothing less than curing paralysis. Now we look at our preclinical studies and our early human studies as simply a step to ultimately when we want this to become part of the mainstream and then part of guidelines. And we've certainly done that with our cardioendocrine studies, and which have been reflected in the new guidelines, for example, on diabetes, our new, essentially investigation and management of endocrine diseases after spinal cord injury. For now, there's a new guideline on it, and it reflects a lot of what we've done over the years, the published studies, the things that we brought to the table in discussion about changing the way endocrine disorders are managed after spinal cord injury, which is to this point rather limited and certainly should be more widely considered as part of the big package of what we see in an individual who has an early and then, as you said, ages with their spinal cord injury.
Yeah, aging with spinal cord injury. And I think the MIND project has always been built around, as you've already mentioned, hearing from our individuals in the community and internationally that are living with spinal cord injury, and actually hearing about what their needs are and how we can direct our research to that. So I'd like to congratulate you and all of your colleagues in terms of your research that's going on. It's making such a big difference in people living with paralysis.
Thank you.
And we're really excited about what you're doing. And again,
if I can, Dalton,
please.
One of the questions, again, I'm kind of the historian.
Yes.
One of the questions I asked Dr. Green in 1984 was, what does a 60-year-old tetraplegic look like? And his answer was, I don't know, I've never seen one.
Yeah.
Well, we see them now, and that's certainly a credit toward every aspect of field stabilization, acute stabilization at trauma centers, far better surgical approaches, and Dr. Green and Dr. Levy certainly get credit for that, but every aspect of patient care that's come throughout lifestyle, okay, from the point of injury to community reintegration, okay, has improved. And now we're challenged to see individuals who are in their 60s and who are having more pain and more challenges in ADLs. And the good thing, again, is the social platforms that we're using allow them to express those things and share with those of us who are scientists but not injured, the types of things that they experience in daily living. And that's also changed our perception, because when I came into this field, the average age of an individual with spinal cord injury was somewhere between 18 and 25. And now the average age is somewhere in the early 40s.
Yes.
And we have an entirely new population who are in their 60s who are having brand new spinal cord injuries from falls. So we've had to change our approaches and our perception of what aging really means. And our research subjects and our clinical patients have been very valuable to us in sharing essentially what they have.
Well said. We've made a lot of progress, but we still have a lot of challenges, and the research is leading us to new questions that we can ask. So again, thank you very much for joining us today. Appreciate the comments, and congratulations again on all your hard work.
Thank you.